So let me go ahead and talk about the other side. So let me go back there. So one of my residents who's interested in spine, she gave me the references, and I started reading them last night. And so, if I don't make sense, you can either blame him or blame me. So we just talked about the fact that there are patients that are very, very different, and then there are cases that are very different. Same-day discharge for very simple cases, and we know that happens, and that's very reasonable. However, a lumbar fusion, some cases may be simple, but some cases are not so simple, and differentiating between one over the other is very challenging. And also, the same-day discharge from hospital versus ambulatory surgery center is different. I'll go ahead and explain why that's the case. Because there is much more limitation in terms of resources in ambulatory surgery center. Lumbar fusion in ambulatory surgery center, I feel right now is not ready for prime time, not appropriate, as the title suggests, not even with a robot. So yes, I do have a robot. So that's my fellow putting a screw in, my resident watching, and I'm watching in the back there as he's doing that. So even with the advanced technology, I don't think it's ready for prime time. So what does CMS say? What does it say about ambulatory surgery center? Ambulatory surgery center are not permitted to share space with a hospital or critical access hospital outpatient surgery department. So what that means is that if you have a trouble with a patient at ambulatory surgery center, you have to pick up a phone, dial 911, and some of the ambulatory surgery centers are quite a distance away from hospital. 2007 Medicare report on ambulatory surgery center said, surgery centers have neither patient safety standards consistent with those in place for hospitals, nor are they required to have the trained staff and equipment needed to provide the breadth of intensity of care. So some procedures, and I want to include the lumbar fusion, most of them are unsafe to be handled at surgery center. So what does news think about this? And this came out a little over a year ago at USA Today, and the title was How a Push to Cut Costs and Boost Profits at Surgery Centers Led to a Trail of Death. And they had to actually look through, because this statistic is not kept by CMS in terms of patient deaths. And what they estimated is that since 2013, more than 260 patients have died who had surgery at ambulatory surgery centers. At least 14 patients died after spine surgeries. The one that was prominently featured in this story, she's pictured right over there, Paulina Tam, 58, mother of three, had surgery at Fremont Surgery Center in Northern California in 2014, and she died. From the story, I gather she had an anterior cervical discectomy fusion. Another patient, James Long, 56, at Colorado Surgery Center for back surgery, also died. And your territory in San Diego, the paper goes on saying that he gasped like a fish, his wife recalled, as they waited for ambulance at the ambulatory surgery center on April 28, 2016, and he didn't make it. So one of the neurosurgeons who is very familiar with the ambulatory surgery center said that because there is a financial incentive, many are doing surgeries at ambulatory surgery center, and sometimes that can lead to problems. So what does the literature actually say? You showed a whole bunch of literature, and it does seem clear, as you pointed out, that we don't really know at this point who are ideal candidates for ambulatory surgery center lumbar fusion. We do agree that some patients can be done and be done safely, but then there are a whole list of criteria that seems to be helpful in terms of earlier discharge, but it has not been worked out. And we talked about the 30-day readmission already, and that is a metric that is being very carefully monitored by my hospital. I'm sure your hospital looks at that too. Insurance companies track this, and our hospital is Blue Cross Distinction Center. We didn't get the plus because of the cost. We charge quite a bit, and that's obviously out of our control. But readmission, 30-day readmission, is a part of the process in terms of negotiating payments. So if you have a very high or outlier in the 30-day readmission, you may not even get the contract. And we talked about the bundle payments, which we have to keep in mind, which raises costs if patients ends up coming back to the hospital. And it is true, lumbar fusion has higher readmission rates than more simple surgeries such as microdiscectomy. So this one looked at NSCIP database, and a fairly large number of patients having spine surgery, and they identified 695 patients that got readmitted within 30 days after surgery. And the causes of readmission, if you look at that, 1/5 of readmission is pain issue, and this is very kind of relevant to the talk that was done earlier. From my experience, even with a simple microdiscectomy, where I feel like patients gonna do fine and otherwise young and healthy, they do end up sometimes coming back to the ER. We try not to admit them, but sometimes they get admitted. And to this day, I don't know why some patients have out of control pain that that person feels like need to come to the ER, but you do have those cases where you can't really predict, and that's something that we have to really work out in terms of doing this in ambulatory surgery center setting. How about the TLIF procedure? I know you show TLIF procedures, and you do that very well. And this is very small in number. It compared the surgeries done at ambulatory surgery center and hospital setting, and it showed there was higher complications with the ambulatory surgery center and leading to ER visits and readmissions within post-op day 7. And when you look at that, again, numbers are very small, pain control and spinal fluid leak. So pain control is one of those things that I think we need to really kind of sort out in terms of how we're going to address that after the surgery, after patients go home the next day, when they start feeling the pain after anesthesia wears out. So how about reoperation after outpatient lumbar fusion? This paper does indicate that reoperation is higher. So outpatient posterior lumbar fusion, 770, inpatient much large number, and outpatient fusion had higher likelihood of coming back for reoperation within a year. And the reasons are revision, extension of posterior fusion, needing to do anterior fusion, and needing to do additional decompression. And this is more recent data that was presented at this year AANS meeting, and it also looked at NSCIP database. And again, in outpatient setting, there was higher risk of 30-day reoperations. So I was kind of thinking, why is that? And I think one of the paper, Don, you were actually, I think, senior author in that, and the paper kind of talks about what may be the reason for that, and I think it makes sense. When you are operating in an ambulatory surgery center, I mean, you have to think about getting the patients done in a quick manner, because if as anesthesia is extended, then patients may not be able to leave. So, and you want to do it, in reasonable quick time. And sometimes it may lead us surgeons to perhaps not do an adequate job in decompression, maybe cut corners. I don't know. I mean, that's just a speculation, but I'm thinking that may be a factor. So in conclusion, lumbar fusion in ambulatory surgery center is not appropriate at this time. It is really hard to predict who is an ideal patient for this type of surgery. Lumbar fusion in ambulatory surgery center. Adequate pain control is more difficult in that setting. Surgeons are under pressure to perform the surgery more quickly. More difficult to defend if you do the fusion surgery and patients end up having serious complication and you get sued. I think how you took care of the patients at the Ambulatory Surgery Center. So with the data that we have available to look at, current real-world practice really does not support lumbar fusion in Ambulatory Surgery Center. And for me, in academic setting, in terms of one of my mission in terms of teaching future surgeons, I think trying to do this more and more in that setting, it gives our trainees less opportunity for hands-on training. Thank you very much.